So welcome to the Health and Care Across the Life course theme meeting. Just a brief introduction from me. So you heard about the research development networks briefly in the meeting earlier, if you were there for the beginning. And we're hosting 3 of those. So just a quick revision for those of you that may have missed the beginning. These are the way that we drive our portfolio of research that we adopted very early on in the ARC. Those of you that remember the Blackpool meeting, at that time we highlighted the importance of looking at social prescribing, and we also highlighted the importance of looking at health and well-being in our coastal areas. And as a consequence, we've set up a couple of the research design networks, as they're now called. One is on seaside towns and communities, improving health and well-being and reducing health inequalities in those. And the other is around social prescribing, which is alternatives to using drugs to help people manage problems, particularly in primary care, but we're looking above and beyond that. And we've also have one on another area of interest that was very widely supported across our theme, which is community mental health. Initially, that was focused on the pandemic, and we talked about post-pandemic, but as we're not quite sure what post-pandemic means anymore, and whether indeed there will ever be something that we can describe as we are now post-pandemic, we have adjusted that slightly to be a more general theme. So those are the 3 research development networks that we have. As I said before, they're here to create knowledge, share intelligence, prioritize research, and to produce grant applications. So we already had a few grant applications emerging from the coastal work, partly because we're linked up to a national group that we help pull together, looking at coastal health and well-being, and we're continuing to do that, and we have some subgroups in that, and these meetings are regularly ongoing and very active. So that's the research development network. So what are we going to do today? So we're going to look at families and children as a sub-theme, and we're going to have quick presentations from Pauline Slade, Antoinette Davey, Pippa Atkinson, and Helen Navuera. And one of those, the last one, was trailed in the earlier discussion about today. Then we're going to have some work from one of our public advisor co-leads. Paul Moran is going to talk about the COVID generation, so the impact of the pandemic on adolescents. And then Dr. Clarissa Giebel is going to give us an update on where we're up to with our older adults sub-theme. And that's enough from me. I'll stop sharing. And Pallavi, over to you. I think it's Pauline now, isn't it? So the first presentation you're going to hear is from Pauline Slade on ESME 3.
Hello, I'm Pauline Slade. I'm Professor of Clinical Psychology at University of Liverpool. I'm going to introduce you to the ESME 3 study, which is looking at the effectiveness and implementation of maternal mental health services. The background and policy context to this is that there is now a national implementation of maternal mental health services, that's MMHS for short, and they are going to be identifying and providing assessment for mental health difficulties associated with trauma and loss in the perinatal period, and then intervention where that's required. And those will be evidence-based interventions as suggested by NICE. And essentially there is some central transformation funding for delivery of early implementer sites, that's 10 across the country, and then a further 20 or so fast follower sites. That's in progress now. The early implementers technically started in April this year, and fast followers are should be up and running by April of 22. Money then will go into the commission baseline, and sites will be scaled up nationally for 23-24. So why is this happening? Well, perinatal mental health problems have a significant impact on health and well-being outcomes for women, children and families. They're associated with long-term costs to health and social care. But the current provision means that some women, particularly those experiencing perinatal loss where there is no baby, or indeed trauma, are less likely to have access to mental health care. And there are also inequalities in access across the system, and many minority and underrepresented groups exist. So who will be benefiting from these services? Well, women with moderate, severe and complex mental health problems, specifically related to the loss or trauma in maternity, neonatal and indeed perinatal contexts. So specifically around PTSD following birth trauma or perinatal loss. So the services will cover sort of early miscarriage, recurrent miscarriage, stillbirth, neonatal death, termination of pregnancy for any reason. And indeed, some services will have a specific focus on children's social care interventions during pregnancy, where there may be separation of an infant from the parent's care due to safeguarding concerns. Tocophobia is also going to be covered in services. So the questions that are going to be addressed are: what's the variation in the maternal mental health service models across the sites? What are the contexts, mechanisms and outcome configurations? Are the services effective in improving mental health for women who've experienced trauma and loss? And are they effective in improving psychological knowledge, skills and confidence in maternity staff? In particular, we're interested in the factors, the challenges and solutions that affected implementation in the early implementer and fast follower sites, and also whether these services are providing equitable access to care, as they do provide opportunities for addressing health inequalities. So there are two phases to ESME 3. Phase 1 is just started and runs till April 22, and this will involve site mapping and program theory development. So we will be reviewing the documents for each site, involving stakeholders in engagement in the program theory development. There will be workshops, focus groups with service providers. The outputs will be the initial program theory development and some identification of early implementation challenges. And we are aiming to have an e-learning event late this year and an interim report in April. Phase 2 will cover organisational case studies at 3 to 4 sites, and that will run from 2022 in January through to September 2023. And these will involve realist interviews with women and staff, routine outcome data collection from women seen, psychological competencies in terms of a staff survey, and we'll be looking at implementation outcomes and health inequalities through surveys. So where are we now? Well, we're setting up phase 1, and what will this contribute? Well, hopefully it will contribute information to further shape maternal mental health services so they better meet women's needs across different contexts, and they introduce effective ways of reducing health inequalities. Thank you.
Thank you, Pauline, for that presentation. Can I please call on Antoinette to give us an update on the ESME 2 project, please? Thank you.
So ESME 2, very similar to ESME 3, is a project around using realist methods to look at the effectiveness of community perinatal mental health services that have been running across England. And we were due to start recruitment at the beginning of 2020 when COVID hit, so we delayed recruitment to April 2020. And we just finished recruitment in June this year. And what we did for this particular work package, so we interviewed mothers who'd been accessing perinatal, community perinatal mental health services either pre-COVID or during COVID. We interviewed their significant source of support, so their partners, their mothers, their sisters, their kind of all different types of family members and friends who provided that support for them. And we interviewed staff within the perinatal services that we selected. So we had 10 services across England, ranging in different types of therapies they provided, staffing models, and also whether they were rural, urban settings. We had 3 in the north, 4 in the southeast, and 3 in the southwest. So this is ESME2 is a collaboration between Exeter University, King's College London, and Liverpool University. So we had those 3 areas managing the kind of 10 sites. We had a target of 250 interviews across the 3 different populations, and we managed to get 273. So we over recruited. In the end, we interviewed 140 mothers, and that ranged across different age groups. The majority fell within the 25 to 34 age range. They had different diagnoses, so a lot of them had depression, anxiety, OCD, PTSD, psychosis, and also personality disorders. A small, about 20% of our sample were from diverse backgrounds, and mostly were employed, and around also 20% were from highly deprived areas across England. Interesting enough, 12% of our mothers who took part had a PTSD diagnosis, and we've analysed these interviews and fed them into ESME3 to help kind of with the development and understanding of what care is being provided for women with PTSD within community perinatal mental health services. We interviewed 54 significant source support, so that included the dads of the babies, grandmothers, aunts, and also kind of close friends who provided support to mums during their time. And we interviewed 79 staff from different professions within the services. So we had a range of psychiatry, psychology, nursing, occupational therapy, pharmacology as well, and nursery nurses. So we were able to capture all the range of professions within the services that have been set up. So at the minute, we are currently analysing all the data that we have, and we're testing our program theory around what makes a good perinatal mental health service, as I mentioned, using realist analysis. So we're developing configurations of context, mechanism, and outcomes to explain aspects of care, such as access to care, quality of care, and also good mental health outcomes. And in November, we'll be hosting a stakeholder event for ESME2 to provide preliminary results to all of our stakeholders and gather feedback as well around the program theory and what we've kind of developed so far. And throughout this process, we've been feeding into NHS England preliminary data to help them understand what care was like during COVID especially. And that's it from me.
Thank you so much, Antoinette.
That's okay.
Thanks for your time today. We move on to Pippa Atkinson. Pippa is one of our PhD students. This is going to give a quick update on her project. Thank you, Pippa.
Hopefully you can see my slide.
Yes, we can.
Brilliant. So for my research, I'll be exploring how the Baby Friendly Initiative revised standards influence the infant feeding journey of women over time. And by that, I mean from the antenatal period up to 6 months after they've had their babies. I used the HiAT initially to consider the various ways in which my research could be undertaken and decided to undertake a comparative study and obtain experiences of women from different socioeconomic backgrounds. Forming my advisory group and recruiting the public advisors that will be accompanying me on my journey has really enabled me to develop the diary that will be used by the women during the study and the documents that supported my RS application. I found discussing the question and search terms I'll use for my systematic review and my public advisors really helped me to ensure the suitability of the question and ensure that I was including all the key words. My systematic review, which I recently started and is now registered on Prospero, will look at what do women, birthing people want from infant feeding communication. For me, I was really excited to get HRA approval for my study in August and confirmation of capacity and capability from the NHS Trust I'll be working with this month. So I'm now all ready to start the next part of my journey and actually set up my study. Thank you.
Thanks, Pippa, for that update. We're going to now move on to Helen Nabuera's presentation. This is a presentation which we would be sending up for prioritization. After the presentation, we'll be asking you to do some voting. So please, can we run that presentation? Thank you.
Hello everyone, my name is Helen Nabuera and I'm a consultant pediatrician at Alder Hey Children's Hospital and also a senior clinical lecturer at the Liverpool School of Tropical Medicine. I'm presenting this project on behalf of colleagues Dr. Shaima Hassan, Dr. Helena Kamarova and Professor Jill Thompson, who I am collaborating with. And the topic is exploring strategies to prevent admissions to acute pediatric services for establishing feeding amongst newborn babies under 7 days of age in the Northwest region. And this has come up very much as a result of our experiences of working in Alder Hey. So breastfeeding is really the backbone of child health globally. And we know that over 800,000 child deaths and over 20,000 maternal deaths could be prevented by scaling up of breastfeeding. Now, in the UK, we have one of the lowest rates of breastfeeding globally. Recent data shows that in terms of breastfeeding initiation, about 74% of women will do that at birth. But unfortunately, this is not sustained, and by about 6 to 8 weeks, only 42% of women will be breastfeeding, and by 6 months, less than 1% of women in the UK will be practicing exclusive breastfeeding. And the Baby Friendly Hospital Initiative is currently obviously being scaled up in UK maternity services, but the pediatric services have not really been involved in this, although there are ongoing discussions around having this in the pediatric units as well. The current target by the World Health Organization and UNICEF is to increase exclusive breastfeeding rates from the current 41% globally to 50% by 2025. So Alder Hey Children's Hospital has a very high intake of admissions to acute pediatric services, and what we noticed was that amongst these children, there were quite a number of infants under 7 days of age who are being admitted for feeding problems, and so this obviously is not ideal because it exposes these otherwise well babies to potentially life-threatening infections, but also there's a negative impact it has on the bonding between mother and baby, in addition to the increased costs to the NHS. So in view of what we were seeing, we decided to undertake an audit really looking at describing these infants who were being admitted with infant feeding problems in the first 7 days. So the first audit was over a 6-month period in 2019 from March to September, and that was pre-COVID, and we then followed this on with another very same audit during the COVID period. So what we found was that in the pre-COVID period, there were over this 6-month period, there were 93 children who were admitted with feeding difficulties, and on the right you can see that about a third of these babies did not have any other concerns with them and therefore did not really need any other interventions apart from feeding support. And during the COVID period, obviously the total number of children who were admitted with feeding difficulties was smaller, nearly half. But when you look at those babies who again had just feeding difficulties as a problem with no other concerns at all, we find that the proportion was actually larger. Over half of those babies did not really need to be in hospital. So in terms of the next steps with this work, we've already had input from the NIHR ARC Northwest Coast public advisors, and we've also presented this at a number of neonatal and maternity unit forums across the region and received some really useful insights and feedback. And really based on that, we would like to go forward and undertake a prospective audit across general pediatric units in the Northwest to capture details of who is referring, reasons for referring, as well as who is being referred to identify any disparities in socioeconomic status, as well as infant feeding outcomes. And to complement this, we also want to conduct qualitative work using in-depth interviews as well as focus group discussions with a selection of women from diverse backgrounds, really to find out what their journey has been in terms of receiving infant feeding support right from the antenatal period right through to the postnatal period. And it's very much to identify any gaps that we can use for the next phase, which will be to co-design strategies to avert these admissions to acute pediatric services for support with infant feeding for those infants under 7 days of age in the Northwest region. And this will involve, having workshops with stakeholders, but also incorporating implementation research strategies to inform knowledge translation on infant feeding. And so I'll finish there. Thank you very much. And I look forward to any questions or comments as we go forward. Thank you.
Thanks, Helen, for that presentation. As I mentioned earlier, this is a project for prioritization, so I'd be asking you to do some voting now. Please, could we have the first question up on the screen? So the question is, first one would be, how would you prioritize this outline proposal for ARC? Do you consider it to be high, medium, low, or not a priority? And the second question is, would you or your organization be interested in participating in this project?
Thank you. Just a note on the voting, please don't forget to click submit once you have chosen your answer. If you scroll down, you just click the submit button. Thank you.
Thanks. Can I just mention also, when you are prioritizing this proposal for ARC, you would be prioritizing it sort of for your member organization. So if we see that you have prioritized high, we would consider that your member organization thinks this as a priority, a high priority. Thank you.
Yeah, just to clarify, we will still be sending out the survey, but at least we will then know which organizations have responded to us so that we don't keep nagging an organization that's already voted in the theme. If you're not the lead for your organization, you should probably contact them and let them know that you've prioritized participation in this project so that they're aware of that, because it might be committing us to contacting you and getting you involved in meetings, which is great, but you just need to let the lead for your organization know if you're not the lead and you're suggesting this is something you want to get involved in. The prioritization is fine. It's that if you want to get involved, you need to let them know. But please do let us know if you want to get involved.
Okay, voting has ended.
Thank you. Thanks a lot. We will be moving on to our next sub-theme, which is adolescence.
Welcome, Paul.
Hi everyone, my name is Paul Moran. I'm one of the public advisors and currently lead on the HaCAL theme together with the Larger Than Life Dorcas. I'm here to talk to you today about some work I'm involved in and to talk to you about a new concept of the COVID generation. Many of you are going to know that I run an amateur boxing club in my community, as well as coaching the kids that come through the door. We've more than ever played the role of a mentor to these kids over the last 18 months. I'm really concerned about the well-being of many of our patrons when outside of our club. The closure of all the clubs and support networks for children during the pandemic has had a massive impact, and I think we're on the very edge of a mental health epidemic amongst the young people. That's going to be a large problem for society and will continue to be felt for years to come. And what am I hearing on the ground? Well, it's mainly the economic and social inequalities for the COVID generation that's hitting really hard at the moment. It's recognised that the pandemic's had an impact on everyone, but the hardest hit have been young people, people from the Black, Asian and ethnic minority communities, and young people living in poverty. My ward's in the bottom 10% of the country for poverty, unemployment and long-term health conditions, and the pandemic's desperately exacerbated these problems. I just want to pick out a few things that have impacted kids I know, and this is backed up from a study from the Youth Access that's been published in the last year. The first one's around digital poverty and the digital divide. So not something I've ever thought about before, but a lot of kids over the last 18 months haven't had access to the internet outside of the school. And during lockdown, when kids were at home schooling, for many this was impossible. Ofcom's technology tracker found up to 2 million kids didn't have access to a laptop or computer over this time, and approximately 3/4 had mobile data, but 500,000 students didn't have access to the internet at all, which was massive for them. All that led to education inequalities, and it's generally thought that children in state schools are now 18 months behind their maybe more affluent peers. Evidence suggests that poorer students are likely to be underpredicted at levels than peers from the more affluent backgrounds, and the postcode lottery of scores was seen amongst many in the last 2 years. This has affected kids in our boxing club, and 3 of them certainly think their scores at GCSEs and A-levels were massively impacted due to the pandemic, and they fear for their future opportunities and lack of career options. Next topic is around poverty. So 4.2 million children currently live in poverty in the UK, and that figure's rising. The BAME, disabled and migrant children populations are disproportionately impacted by poverty. The Joseph Rowntree Foundation found that 40% of renters had a reduction in income and have spent less money on the basics such as food. We've seen that kids have stopped coming to our boxing classes, and when we've caught up with them and their parents, the reason is because they can't afford a £1 fee for a 1-hour session. So of course we got these kids back in for free, but it just shows kind of, you know, the margins that people are working with. The pandemic's seen a massive increase in short-term placements in foster care, and Bernardo's fostering services have seen a 60% increase. Young people in care do find it more difficult in education, and they find it more difficult to access apprenticeships, and they're a lot less likely to go on to higher education. Unemployment, young people aged 16 to 25 have felt the worst of the pandemic in terms of employment. Lots of jobs in the retail and entertainment sectors suffered, where they were far more likely to be furloughed and not being able to work from home. Proprius, the youth suicide prevention charity, has seen a higher number of contact from young people with fears of impact of reduced or removed income. Young people in the northwest and northeast have been hit worse, and the unemployment is expected to increase as the furlough ending hits. Even young people who have pushed through to higher education will see the reduction in the graduate and entry-level positions in companies as they tighten their belts. I've got 2 young lads in our club that have had to stop college courses and try and find work, as the parents couldn't support them as they've lost their jobs, and they now fear their ambitions have stopped and their career ambitions are ended. Incomes, so families on low incomes, women, young people and people from a BAME background who are considered to be seeking already in work poverty have been hit the hardest during the pandemic. Nearly 18 million people have turned to some kind of credit or debit to get through the pandemic, and the charity Step Change has seen a big upsurge in 18 to 24-year-olds contacting them saying that the pandemic was the reason for their debts, and 40% have stated that they often run out of money before the end of the month. Benefits in 2020, nearly 4.6 million households receiving universal credit, which is a 90% rise in 1 year. 1 in 3 of those people were under 25, with Liverpool and Blackpool seeing some of the worst figures. The removal of the 20% uplift in benefits will also see 750,000 families plunged into crisis, according to the Fabian Society. Housing in 2019, it was thought there were 135,000 children either homeless or in temporary accommodation. This figure is bound to have risen in the last year. The figure doesn't include young people that might be self-preserving or living with friends or relatives. And according to the government, figures up to 1 million families have fallen on hard times and stopped paying rent, council taxes or utilities. And I think we all know that the ask on food banks has become enormous, even with working families needing to rely on regular support. This is all happening in our communities right now. So it doesn't matter what your job is, what your social standard, what your race, religion, colour or beliefs are. There's many separate impacts on young women, young black people, youngsters from the South Asian communities and the LGBTQ plus community that I haven't even called out today. And I could speak about this all day if you let me. But how can a young person stay positive? How can they look forward to the future and break free from the COVID generation? I just don't know. I haven't got all the answers. But what can we do? I think we can bring a voice to these people. We've started some seldom heard voices groups which Selena's been running and will continue to revisit. We can consider not only the voice of all young people that we house, but specifically some of the smaller groups that have been disproportionately impacted by the pandemic. We can seek out young people to become public advisors and let them share their experiences and concerns, and maybe we can get some projects starting to look at the COVID generation. If anybody would like to contact me separately after this, please feel free to. Thanks very much. Bye.
Hi, my name is Clarissa Giebel and I'm the Senior Research Fellow in the HaCAL theme. Today I'm going to give you a brief update on some of the research in the older adults sub-theme. As I just mentioned, this is only going to be a brief overview because there's a lot of research going on. And also just to mention before I start that we're always actively looking for more members and people affected by dementia or frailty or caring for someone to be involved in research, in shaping research, in the conceptualization and in the conduct of research. So please, if you are interested with lived or professional experiences, then please drop me an email. And next slide, here we go. So to start us off, I'm going to give you a brief overview of some of the key findings from our COVID-19 care home study. We've collected remote interview data from 42 family carers of residents living in care homes, as well as care home staff in October, November 2020, and we followed this up, a subsample of those, 20 to be precise, in March 2021. So between that time, obviously there was the vaccination rollout and increased testing in care homes. We wanted to understand the experiences of staff as well as family carers of safe care home visitation and generally how the restrictions have impacted on the care home setting more broadly. Some of the key findings that we've highlighted here are there's been a very, very fine balancing act between providing adequate care and infection management by care home staff, which was characterized by a clear lack of guidance and communication from the government to individual care homes. But also there was a lack of communication between care homes and family carers, which led to a lot of negative feelings between those groups. We've also found that there were obviously very difficult and new job demands to the role of working in a care home. Sourcing PPE, wearing PPE, increased working hours, overworking, as well as staff sickness because of COVID, but also having to facilitate these new types of what we call alternative face-to-face visits. So seeing your loved one behind a window, behind a pod screen, or via Zoom. Now suddenly these all had to be supervised by staff and arranged. All these different aspects seem to have impacted very negatively on the mental health and mental well-being of family carers and staff, but also on residents. Many residents didn't seem to understand, according to staff and family carers, why these restrictions were in place, why they weren't allowed to see their loved ones. And this really needs to be addressed, the poor mental health. We've also looked a bit on the end-of-life care angle, obviously because it's the care home setting. Some of the recommendations here that are resulting from this study are that social contact is absolutely vital and family members need to be enabled to visit. Obviously, we conducted the study up until March and now things have changed, but really for future pandemics or for future waves of the pandemic, social contact is vital. And remote contacts really don't work that well for many. There needs to be much clearer guidance from the government to care homes, but also from care homes to family carers. And generally much more support, both in terms of training for staff as to how to conduct their role, their new role, I suppose, as well as psychological support for everyone involved, residents, families, as well as staff. And also based on the data, based on those findings, we do make the recommendation that COVID-19 vaccination should be mandatory for staff, because it appeared that staff brought in the virus as opposed to family carers. And building on from that, we've done an international comparison with the Netherlands. Specifically, we've had in total 125 interviews, because both studies, the UK one and the Dutch one, they looked at safe care home visitation roughly around the same time as well. And whilst there were very strong similarities and the negative impact on the well-being of families when they were not able to see their loved ones, what was striking was that in the Netherlands in May 2020, the government introduced clear guidance enabling safe care home visitation, which really had a positive impact for continued opening of care homes, which was obviously very different in the UK. Another international collaboration with the same team in Maastricht University was an Alzheimer's Society funded study, which looked specifically at health inequalities and inequalities in accessing post-diagnostic dementia care in the UK and in the Netherlands. And this study was taking place before the pandemic. Unfortunately had to stop, but then we could luckily resume it again. And we collected carer surveys as well as remote interviews and face-to-face interviews. And whilst we noted similarities in inequalities and barriers to accessing care, such as lack of funding, lack of awareness, lack of suitability of the services, as well as many people were lacking that faith or trust in the services to help them to get better or maintain an adequate level of well-being. One key enabler, which was found much more strongly in the Netherlands, was a single point of contact after a diagnosis, or often a case manager, who would regularly contact the person with dementia as well as the carer to really enable those links between themselves and services. And going a bit further afield, so looking further than Europe, we're also actively collecting data both in the UK and in Colombia on our 3-year project with a university in Medellin in Colombia to understand the impact of stressful life events on the mental health of older adults, specifically in the Turbo region. So we started our systematic review doing qualitative data collection, and here you can see one of our collaborators actively in the field collecting data with an elderly gentleman. Linked to that, we have also now completed our data collection on the long-term psychological impacts of restrictions on older adults in LMICs, specifically looking at India, Uganda, and Colombia, and we've done baseline and follow-up interviews. So now we're having a lot of data, a lot of transcripts to code. So watch this space. A little bit of a shout out about a couple of new projects which have commenced this month. One is run with the International Longevity Centre UK, and we are specifically looking at finance management in dementia and how people with dementia plan their finances and finance their care. So as part of this, pending ethics, we will be talking remotely to people living with dementia in the early stages of the condition, as well as family carers, current as well as former carers. So if you are interested in taking part, please drop me an email. And we're also linked up with the Weld into Practice Care Home Implementation Project, which is run by ARCFEST. And as part of this, they're looking to implement across care homes in England a specific staff training program to improve the well-being of people living with dementia. And finally, just to give another little bit of a shout out to the Dementia and Aging Research Forum, the next forum event will take place on the 17th of November, virtually again. And if you are interested in how big data can be used to improve the lives of older people living in care homes, please sign up. We will have Dr. Stephanie Harrison from the University of Liverpool giving a talk there and sharing her research. And also, let's not forget the virtual third annual conference on the 3rd of November, where we will have a lot of academic but also non-academic speakers, including the Liverpool DAA, for example, and a carer as well. So that's all we've got time for. Thank you very much.
Thank you very much. So just before we rush off for our break, Pallavi, I see your hands up, but I'm going to say just before that, our next theme meeting is on the 5th of November. So going, would say going out with a bang, but we're not going out, but that's bonfire night day, 11 to 12:30. So please do sign up for that and come and join us to talk more about the theme. It's usually much more interactive in the interim meetings. So rather than listening, you'll be engaging much more, I hope. And if you know adolescents, for example, who want to get involved in the work that Paul's been talking about, then please link them up with us and let them know about the Seldom Heard Forum so they can ensure that their voice is heard and they can get involved in that work. Plus anybody you know who may be involved in supporting adolescents and their mental health. And of course, if you're interested in any of the other projects, please let us know. I don't think we have the voting yet result, but I'll announce that later. Oh, we do. So so lots of support for that, and quite a lot of organizations wanting to get involved. So we'll follow that up with you. Thank you very much indeed. I think that's all we need to do today. So thank you very much for attending, and I'll see you at the main meeting after the break at 11:10. Thank you very much, everybody. Unless Pallavi had anything you wanted to say?